This is part two of the lecture on zoonotic and vector-borne diseases. I'll go over some pathogens, including some that pose unique threats to the health of humans, animals, and ecosystems in Alaska and the circumpolar north.
In part one of this lecture, I use this Venn diagram to show the relationship between vector-borne and zoonotic diseases. As I go through examples, you'll see a miniature version of this Venn diagram in the upper right corner to indicate how each disease is classified. Malaria is caused by parasites in the genus Plasmodium, including species Falciparum, Vivax, and Ovale. The incubation period in most cases in malaria ranges from 7 to 30 days, but varies by parasite species. Most transmission occurs when a female Anopheles mosquito that's infected with malaria parasites bites a person. Less commonly, malaria can also be transmitted vertically by sharing needles, through organ transplantation, or blood transfusion. Mosquitoes inject some of their saliva into the person when they bite, and the parasites use this as an opportunity to get into the human bloodstream. When a female Anopheles mosquito infected with Plasmodium bites a person, sporozoites in the mosquito's saliva enter the bloodstream and travel to the liver. Within liver cells, they mature, and in the case of Plasmodium vivax and Plasmodium ovale, they can remain dormant in the liver for weeks or even years, only to erupt again later and cause another episode of illness. Following replication in the liver, the parasites multiply within erythrocytes. People experience clinical manifestations of malaria during this stage when parasites are invading red blood cells. It causes high fevers with shaking chills and generalized pain. Untreated malaria can progress and sometimes is fatal in less than 24 hours. When a mosquito bites the person with malaria, it ingests male microgametocytes and female macrogametocytes, which then invade the midgut wall of the mosquito to grow into oocysts that rupture to release sporozoites. The tiny sporozoites migrate to the mosquito's salivary glands to get ready to infect the next human. Malaria used to be a problem in the US. First Lady Lucretia Garfield contracted malaria in 1881, which raised awareness of the risk of malaria in DC nationwide. At a regional prevalence of 30% in the 1930s, malaria was impairing economic development and military training because troops at bases in endemic areas couldn't train outdoors when mosquitoes were most active. President Franklin D. Roosevelt signed the Tennessee Valley Authority Bill in 1933, which was focused on preparing the area around the Tennessee River for potential development and a hydroelectric power plant. The project spurred formation of an organized malaria control program, which drained standing water in and around urban areas to eliminate mosquito breeding habitats and performed community-wide DDT spraying. This was followed by the National Malaria Eradication Program, which started in 1947 and worked across 13 southeastern states. Malaria was effectively eliminated in the 1950s and was declared eradicated from the United States by the World Health Organization in 1970. Much of the U.S. still has Anopheles mosquitoes capable of transmitting malaria, so there is a risk it could return in the future. Most cases occur in tropical and subtropical areas below 1,500 meters elevation. The vast majority of cases and deaths from malaria are in Africa. Nearly half of the world's population is at risk of getting malaria. Most people who die of malaria are children under age 5. There are medications that can be taken to prevent malaria, known as chemoprophylaxis, but this is often more feasible for travelers rather than for people living in endemic areas their whole lives. All medications have side effects, and the best choice of medication to prevent malaria varies based on an individual's medical conditions, the level of risk for their location, and the local prevalence of resistance to specific antimalarial medications. For travelers and permanent residents alike, chemoprophylaxis should be used as one component of a multi-pronged approach to prevent exposure to malaria. I'll summarize these strategies for all mosquito-borne diseases after the disease-specific information. In 2021, the World Health Organization recommended the first malaria vaccine for use in children living in areas with moderate to high risk of Plasmodium falciparum malaria transmission. The Phase 3 clinical trial found the vaccine reduced severe malaria by 30% and reduced all-cause mortality in children by 13%. In 2023, a second malaria vaccine was approved for residents of endemic areas, which demonstrated 68% protection in residents of areas with year-round transmission. Dengue is transmitted by infected Aedes aegypti and Aedes albopictus mosquitoes. Vertical transmission can occur, and infection during pregnancy increases the risk of preterm birth, low birth weight, and fetal distress. Most dengue infections are asymptomatic or mild, which contributes to how unreliable dengue incidence data is because many cases go unreported. Dengue causes a flu-like illness with a fever up to 104 degrees. While most people recover after 1 to 2 weeks, a minority of patients progress to a more serious illness known as dengue hemorrhagic fever. The warning signs of progression to dengue hemorrhagic fever typically develop suddenly 1 to 2 days after the fever has resolved. Patients often present with severe stomach pain, persistent vomiting, bleeding from the gums and nose, bloody urine, stool, or vomit, bleeding under the skin, shortness of breath, fatigue, and irritability or restlessness. Clinically, patients with dengue are monitored for low blood pressure, given fluid and electrolyte replacement, and transfusions to replace blood loss as needed. Pain is managed with acetaminophen, but there is no specific medication to treat dengue. People who have recovered from dengue have long-term immunity to the type of dengue virus that they were infected with, but not to the other types of dengue. The risk of dengue progressing to dengue hemorrhagic fever increases with each subsequent dengue infection. From 2000 to 2019, the World Health Organization documented a tenfold surge in reported cases worldwide, increasing from 500,000 to 5.2 million. After a slight dip during the onset of the COVID-19 pandemic, dengue began to spread even more widely in 2023, and the outbreak in 2024 in the Americas eclipses any previous epidemics. The incidence of dengue reached a record high in 2024, with over 14.6 million cases and more than 12,000 reported dengue-related deaths. As an example of how dengue in 2024 compared to the prior year, this data from Brazil shows weekly reported cases by year. Dengue now causes about 100 million symptomatic cases and 40,000 deaths annually, making it the most prevalent viral infection transmitted by Aedes mosquitoes. Dengue incidence is highest in Southeast Asia, the Western Pacific Islands, Latin America, and Africa, but it's been spreading to new areas, including local outbreaks in Europe and southern parts of the United States. There's currently 2 vaccines to protect against dengue. Denguevaxia is a live attenuated vaccine that protects against all 4 serotypes of dengue and became available in 2015. But it's only approved for use in people aged 6 through 45 with a previous laboratory-confirmed dengue infection who reside in endemic areas. This is because the vaccine can actually make future dengue infections more severe in dengue-naive recipients. Another vaccine, Qdenga, that just came out in 2022 has been recommended by the World Health Organization to prevent dengue in people without a previous dengue infection. Zika is caused by a virus in the flavivirus genus, which includes dengue, West Nile, yellow fever, and Japanese encephalitis. Like dengue, Zika is primarily transmitted by Aedes aegypti and Aedes albopictus mosquitoes. You'll notice in the upper right, I put Zika on the border between vector-borne only and both vector-borne and zoonotic. That's because Zika virus is maintained in an enzootic cycle, also known as a sylvatic cycle, in which Aedes mosquitoes become infected when they feed on infected non-human primates. Infected mosquitoes are then able to transmit the virus to other primates, including both humans and non-human primates. Most human transmission of Zika virus is from infected mosquitoes, not directly from other primates. But forest-dwelling non-human primates are an important natural reservoir for the virus. Zika also has an urban or peri-urban transmission cycle, in which humans are considered the only reservoir host. Infection with Zika virus causes a febrile illness with a rash, joint and muscle pain, conjunctivitis, headache, pain behind the eyes, edema, and vomiting. Zika virus is known to cross the placenta and damage fetal neurons. It's associated with birth defects, including microcephaly and a progressive form of paralysis called Guillain-Barré syndrome. Birth defects are not limited to symptomatic infections during pregnancy. 5.3% of people with symptomatic Zika virus infection during pregnancy had a baby with Zika-associated birth defects, compared with 4.2% or 1 in 25 of people infected with Zika who had no symptoms during pregnancy. Microcephaly is a head size 2 standard deviations below the mean, about the third percentile, based on age and gender. Microcephaly is associated with significant cerebral atrophy, intellectual disability, including impaired language development, epilepsy, cerebral palsy and impaired motor function, feeding problems, hearing loss, and visual impairment. The first documented outbreak of Zika virus was in 2007 in Micronesia. In 2015, there was a global outbreak first detected in Brazil. Zika was declared a public health emergency of international concern in 2016. Incidence has decreased since, but Zika virus persists globally and is endemic in tropical regions. While there has been transmission of Zika in the United States, the only cases in Alaska were associated with travel. Our cold climate prevents tropical species like Aedes aegypti and Aedes albopictus from establishing permanent populations here. These maps were created using predictive models of the possible geographic ranges for Aedes aegypti and Aedes albopictus mosquitoes in the contiguous United States. While both species are important vectors, Aedes aegypti are more likely than Aedes albopictus to transmit dengue, chikungunya, Zika, and other viruses. The primary strategy for reducing the risk of diseases transmitted by mosquitoes is to avoid Aedes mosquito bites. Aedes aegypti like to lay eggs in artificial containers around homes, so it's especially important to eliminate standing water in areas with Zika and dengue. Controlling vectors by spraying insecticide community-wide has obvious repercussions, such as the example of DDT, which caused bald eagles' eggs to become thin and break and nearly led to the extinction of the species. Interestingly, the primary reason DDT use was discontinued in the early 1970s internationally wasn't because of the negative impacts on other species, it was because many Anopheles mosquitoes became resistant to it. Similarly, many Plasmodium species developed resistance to chloroquine. Larvicides such as BTI, known as mosquito bits or mosquito dunks, are applied to bodies of water where mosquitoes breed, but they make water unsafe to drink and can have unintended effects on other species. Mosquito fish, guppies, and even goldfish have been intentionally introduced into ponds and rivers for many decades as a biological control method to combat malaria. While some studies have demonstrated short-term reduction of Anopheles mosquito larvae when ponds and rivers were stocked with larvivorous fish, a 2017 systematic review by Walsh and colleagues found insufficient evidence of a sustained reduction of Anopheles mosquitoes and of malaria transmission resulting from fish stocking to justify this intervention. The authors recommended against larvivorous fish stocking unless implemented as part of a controlled research study that will also examine the effects on native fish and other species. In many ecosystems, this strategy has been documented to have significant negative impacts on non-target species. For example, native fish species and tadpoles that will later become frogs also rely on mosquito larvae as a food source. So if guppies are eating them all, many other species don't have enough food to survive and reproduce. There have been some pretty cool advances in mosquito vector control in recent years. Wolbachia is a bacteria that naturally occurs in many insects, but not in Aedes aegypti mosquitoes. Researchers infected Aedes aegypti in the lab with Wolbachia and found that the infected mosquitoes were much less likely to transmit viruses from person to person, including Zika, yellow fever, and chikungunya. This method has been scaled up by infecting mosquito embryos in the lab and breeding colonies of mosquitoes infected with Wolbachia, then releasing them into cities. Females infect male mosquitoes with the bacteria and also transmit it vertically to their offspring, so the lab-infected embryos lead to lots more infected mosquitoes. This graph from the first large trial of Wolbachia-infected Aedes aegypti mosquitoes in Indonesia shows rates of dengue in areas where the infected mosquitoes were released compared to nearby areas without Wolbachia treatment that served as the control group. The pink shaded area shows when the trial began. The areas where mosquitoes infected with Wolbachia were released are shown in red, while the untreated areas are blue. The release of Wolbachia-positive mosquitoes dramatically reduced the rates of dengue compared to areas without the treatment. Another example of a biological method that's been developed and implemented in recent years is irradiating male mosquitoes to sterilize them and then releasing lots of sterile males into the population. So they mate with female mosquitoes, but then no offspring are produced. And so many of these sterile male mosquitoes are released that they outcompete the fertile males. While insecticide-treated bed nets are helpful for preventing malaria and other mosquito-borne illnesses in some regions, Zika, dengue, and some other infections are transmitted by Aedes aegypti and Aedes albopictus mosquitoes, which bite during the day, so bed nets provide no protection. Use of mosquito repellents is an important personal protective strategy. DEET, picaridin, and IR3535 are all safe to use during pregnancy. As of October 2025, the vaccines for dengue, malaria, and chikungunya are not approved for use in the United States. The chikungunya vaccine was FDA approved, but that was retracted in 2025. And there's not yet a vaccine to protect against Zika in any country. Lyme disease is a bacterial infection caused by the spiral-shaped Borrelia burgdorferi. In the US, the two vectors that carry the pathogen are black-legged or deer ticks and western black-legged ticks. Lyme disease is the most common vector-borne disease in both the United States and Europe. The risk of tick-borne diseases is increasing globally due to changes in climate, land use, global trade and travel, and increased human-animal interactions. Lyme disease is most prevalent in the Northeast, but incidence has increased in recent decades in part due to ticks increasing their geographic range as the climate warms. While there have been no confirmed locally acquired cases of Lyme disease in Alaska, there is a risk non-native tick species could be introduced here. Incidence is highest from spring to early fall, with a peak in the summer when ticks are most active. Most ticks go through 4 life stages: egg, 6-legged larva, 8-legged nymph, and adult. After hatching from the egg, the larva feeds on a mouse or bird, then the larva falls off the reservoir host and transforms into a nymph. If the host is already infected with Borrelia burgdorferi from a previous tick bite, the larva likely will become infected, so it'll spread the bacteria from the mouse to the next host it feeds on. The nymph remains dormant over the winter. In the spring, it attaches to a new host, usually a larger mammal, which could be a human, because at this stage the nymph is about the size of a poppy seed, so it's difficult to see. Once fed, it detaches and hangs out in foliage to look for its next meal. Deer are the preferred host, but a human, horse, or other mammal may be targeted. After this meal, the nymph is able to grow into an adult. The adult goes dormant for the winter, and in the spring, the adults are able to lay eggs. With each blood meal ticks need to molt and develop into the next life stage, there's a risk of transmitting pathogens to the next human or animal host. Surveillance of nymphs in the Northeast and Upper Midwest has found a Borrelia burgdorferi prevalence of 25%. So how much is Lyme disease increasing? Answering this question requires high-quality public health surveillance data collected consistently over time. In 2022, in an effort to decrease the workload for public health professionals, the CDC revised the case definition for Lyme disease. The new case definition relies on laboratory data only in areas where Lyme disease is highly endemic. Previously, a public health professional would have needed to do a chart review for every case to make sure the clinical symptoms and exposure history consistent with a Lyme disease diagnosis were present. While relying on laboratory data saves time for public health professionals, there are some drawbacks to this change in the case definition. When a person first gets infected with Lyme disease, usually about 7 days later, but as soon as 3 days after, the person develops a flu-like illness with fever, chills, headache, and body aches. About 80% of people develop the classic erythema migrans rash that may develop a central clearing, making it look like a bullseye. There's variability in how the rash looks, though, so the exposure history is always an important part of diagnosing acute Lyme disease. Erythema migrans typically occurs at the site of the tick bite and is sometimes swollen and warm to the touch. But it's not itchy and it's usually not severely painful, which can help differentiate it from some similar looking rashes. About 20% of people who get acute Lyme disease never see that classic rash. Sometimes this may be because the rash occurred on their scalp or on their back, somewhere where it couldn't be seen. Left untreated, some people will clear the infection, but others will go on to develop systemic symptoms around 6 months later. At this stage, people can get that erythema migrans rash all over their body, not only at the site of the tick bite. The bacteria can cause an inflammation of the heart, which results in heart palpitations and dizziness. People get neurological symptoms, including facial palsy, where half the face droops, nerve pain, and sometimes meningitis. Months to years later, in late disseminated infection, people most often have arthritis, but they can continue to have cardiac symptoms and neurological symptoms, including fatigue, sleep disturbance, foggy thinking, and difficulty concentrating. Post-exposure prophylaxis with an antibiotic is only recommended for patients presenting for care within 72 hours of removing a tick confirmed to be an Ixodes vector species, which occurred in a highly endemic area, and the tick was attached for more than 36 hours. If these criteria aren't met, it wouldn't be considered high risk, so no antibiotic post-exposure prophylaxis is warranted. We mostly treat Lyme disease with doxycycline, though other antibiotics are used for people with an allergy, for children, or for women who are pregnant or breastfeeding. The duration of treatment depends on what stage the person is in and whether they have more serious symptoms. When we treat Lyme disease early, antibiotics are very effective. Most people are fully cured. When people first present for treatment later in the course of disease, treatment is still helpful, but a higher percentage of people still have symptoms. A small percentage of people who are treated with antibiotics have arthritis and other symptoms for many years, but this is thought to be an immune-mediated syndrome, similar to what we saw with many people getting long COVID during the pandemic, so additional antibiotics are not helpful or appropriate for these individuals. The infection is gone, the symptoms are being caused by the person's own immune system. The Infectious Disease Society of America, IDSA, recommends that the diagnosis of acute Lyme disease should be based on clinical presentation and exposure history. They recommend against serologic testing in most cases. The recommendation against lab testing is in part because the most widely available test for Lyme disease is an antibody test, and it takes at least 4 weeks for the body to develop the type of antibodies the test can detect. So we would never want to delay treating a person while waiting for that test. Another problem with this test, which ties back to what I was saying about the issues with the new case definition for highly endemic areas, is the antibodies against Lyme disease remain in a person's bloodstream for many years following an infection. So if we rely only on laboratory testing, we'll miss all the people with acute Lyme disease who have had the infection for less than 4 weeks and were just diagnosed in a primary care office or an emergency department, but will accidentally report as incident cases people who had the disease years ago and no longer have it. The clinical guidelines recommend against testing for Lyme disease in most cases. Laboratory testing is only recommended for certain specific cases. For example, serum antibody testing for Borrelia burgdorferi is recommended for patients suspected of having Lyme neuroborreliosis, which occurs when systemic infection spreads to the peripheral or central nervous system. Testing would be recommended for someone hospitalized with meningitis that might be due to Lyme disease. I've been a primary care nurse practitioner for over a decade, and I can only think of one case off the top of my head when I ordered serologic testing for Borrelia burgdorferi. I've diagnosed acute Lyme disease clinically more times than I can count, though. I ordered an antibody test that one time for a hunter I thought might have Lyme arthritis, who had likely past exposures while deer hunting in a high-risk state, but no prior testing or antibiotic treatment. If you think about what type of patient would be tested, it can help you see why the new case definition would miss a lot of incident cases of Lyme disease, but would incorrectly capture a lot of prevalent cases of Lyme disease because people still have those antibodies for years after the infection. In addition to the concern about whether the revised case definition for Lyme disease can accurately capture incident cases, this change to the data is unfortunate because it prevents us from being able to compare incidents of Lyme disease with the old case definition to after the change, so we're left not really knowing how much Lyme disease has increased since 2022. That sudden dramatic increase we saw when the case definition changed is probably mostly due to many prevalent cases incorrectly being labeled as incident cases. A lot of the increase was in older adults, so they may have presented with symptoms of arthritis or other chronic diseases and ended up getting tested for Lyme disease, but that might not even be the cause of their symptoms, and they aren't an incident new case if they had Lyme disease years ago. The risk of tick-borne diseases can be reduced by using insect repellent, checking for ticks, and removing attached ticks using tweezers. Wearing light-colored clothing with long sleeves and pants, and tucking your pants into your socks makes it easier to see ticks before they bite. Ticks will often crawl around on a person for hours before actually biting. It's also a good practice to shower within 2 hours after spending time outdoors, so you can look for ticks and also hopefully rinse off any that are crawling around but haven't bitten yet. For transmission to occur, the tick usually needs to be attached for more than 24 hours, so doing a tick check after hiking can prevent exposure to the bacteria. Ticks should be removed by grasping the head as close to the skin as possible and pulling away from the body at a 90-degree angle. You can wash the skin with normal soap and water. There's a lot of misinformation out there, but simply removing the tick with tweezers is the only treatment needed for most tick bites. Once you've removed a tick, it's helpful to identify the species, which helps determine the likelihood the bite may have caused exposure to a disease. For example, you can send it in to the Alaska Submit a Tick program to help researchers identify potential health hazards and monitor where species known to be vectors for pathogens are present. Testing the tick for Borrelia burgdorferi takes several weeks, so we wouldn't wait to treat a human until finding out if the tick tested positive. Research also hasn't found a high rate of concurrence between humans actually getting Lyme disease and whether or not the tick had the bacteria in it, so this is helpful data to collect from a public health standpoint, but it's not very helpful clinically. Rabies is a viral zoonotic disease transmitted directly from infected animals to humans through bites or sometimes scratches. The virus is transmitted when infected saliva gets into a wound or mucous membrane. There's two types of rabies, furious rabies and the much less common paralytic rabies. Furious rabies causes fear of water, agitation, aggressiveness, hallucinations, foaming at the mouth in dogs, and attacking and biting anything that moves. Paralytic rabies causes an ascending motor weakness and paralysis. Weakness of the facial musculature is often the first symptom of paralytic rabies that appears when the person is still conscious. Wild animals with paralytic rabies are often lethargic and unable to stand up or wobbly on their feet, and the virus causes them to lose their natural fear of people. The case fatality rate for rabies is nearly 100%. Once the virus infects the central nervous system and symptoms appear, it's nearly always fatal. As of 2025, 31 people have survived rabies infection for at least 6 months, nearly all of whom suffered severe permanent neurological sequelae. Many of those who were alive at the 6-month mark died later of their illness. The reservoir host and rabies virus variant varies by geographic region. In Alaska, we have the Arctic fox rabies variant, so many of the reported cases in animals are on the west coast, including around Nome and the North Slope, where Arctic foxes are common and rabies is endemic. All mammals are susceptible to rabies, so red foxes, wolves, dogs, reindeer, bears, or even moose can be infected. Rabies occurs worldwide, but it's classified as a neglected tropical disease because most cases are in Africa and Asia. 40% of cases are in children under age 15, and 99% are caused by dog bites, or less frequently, dog scratches. Less than 1% of human rabies cases are caused by bat bites. Rabies is a vaccine-preventable disease. These deaths could be averted by vaccinating all dogs against rabies and by increasing human access to vaccines and post-exposure prophylaxis. We have both pre and post exposure prophylaxis for rabies. Pre exposure prophylaxis with the rabies vaccine is recommended for people who work with animals that could have rabies, those who live where rabies prevalence is high but access to medical care is limited, and people who work in a laboratory with rabies virus. Rabies vaccine used to be a 3-dose series, but the guideline was changed now to recommend a 2-dose series of rabies vaccine given at days 0 and 7, and then antibody titers can be checked regularly depending on the individual's risk level. The new CDC guideline stratifies people into risk categories. People who work with rabies virus in a lab would be category 1 and should get an antibody titer every 6 months, and people who frequently handle bats or perform necropsies would be category 2 and should get an antibody titer every 2 years. This deviates from the previous recommendation. We used to give 3 doses to everybody who is high risk. For example, when I worked for the National Park Service, I vaccinated all of the people who work on the bear team for rabies because they frequently come in contact with wild bears, so they're at risk of being bitten or scratched by bears. The focus on titers is new, but because rabies antibody titers may not be accessible to people in all settings, the new guidelines do allow for people at high risk to just go ahead and get a 3rd dose of vaccine. Similar to the stratification of risk for pre-exposure prophylaxis, the updated guidelines stratify people by risk category based on the wound and type of exposure. Rabies vaccine is part of post-exposure prophylaxis if indicated based on the wound for both previously vaccinated and previously unvaccinated people, but those who were previously vaccinated require fewer doses of the vaccine. Rabies immune globulin is only for people who have not previously been vaccinated for rabies following an exposure, and it's given as a single one-time dose as soon as possible with the first dose of rabies vaccine, but injected into a different part of the body. The idea is for the rabies immune globulin to help before the body can react to the vaccine to develop its own antibodies against rabies. Brucellosis is a zoonotic disease caused by gram-negative intracellular bacteria in the genus Brucella. Brucella species thrive in cool, moist environments and infect a wide variety of species, including caribou, elk, bison, foxes, dogs, bears, seals, sea lions, and whales. Globally, Brucella melitensis, which primarily affects sheep and goats, is the most common cause of human infection and is also the most virulent species. Infection can result from exposure to as few as 10 organisms. Other Brucella species can also cause serious disease in humans. Brucellosis occurs worldwide and is endemic in parts of the Mediterranean, Sub-Saharan Africa, the Middle East, Central and South Asia, and Latin America. Incidence in the US is now 100 to 200 cases annually, which is significantly lower than it was many decades ago before widespread animal vaccination programs and milk pasteurization. Historically, most US infections were linked to unpasteurized dairy products from infected cattle. People at the highest risk of infection include veterinarians, farmers, hunters, slaughterhouse workers, wildlife biologists, and people who consume unpasteurized dairy or handle meat products. Caribou and other animals may have a swollen knee or swelling of the scrotum or udder, but some infected animals show no signs of infection but can still transmit the bacteria. Vertical transmission in utero or while nursing can occur for both humans and other animals. Contact transmission can occur through wounds or mucous membranes, by ingesting unpasteurized milk or undercooked meat, or inhalation of contaminated aerosols. The incubation period is 1 to 2 months on average, but ranges from 5 to 60 days. In humans, brucellosis typically causes an intermittent flu-like illness with fever, chills, night sweats, fatigue, headache, myalgias, and arthritis typically in one joint. Chronic infection can lead to polyarthritis, endocarditis, meningitis, and granuloma formation as the bacteria spreads through the lymphatic system. People can be infected with brucellosis more than once and with different species of the bacteria. Brucella species have an affinity for the reproductive systems in both humans and animals. In animals, the bacteria crosses the placenta and uses the sugar erythritol as a food source. Humans don't have erythritol, So the risk of abortion due to brucellosis infection during pregnancy is lower in humans compared to other animals. Birth products from an infected animal are often highly contaminated with the bacteria. In addition to the placenta, it's also spread in vaginal discharge, semen, urine, and milk. Diagnosis relies on both clinical and laboratory findings. An antibody titer greater than 1 to 160 combined with compatible symptoms is suggestive of infection. Definitive diagnosis requires isolation of the organism from culture, which takes weeks because Brucella grows slowly, or demonstration of at least a fourfold rise in the antibody titer between samples collected at least 2 weeks apart. PCR and ELISA testing are also available for humans. Humans with brucellosis are treated with multiple antibiotics, usually including doxycycline, for at least 6 weeks. Personal protective equipment to prevent skin and mucous membrane contact with contaminated tissues and fluids, or inhalation of aerosols during field dressing, butchering, and necropsies can limit exposure. Cooking meat to an internal temperature of 160 degrees Fahrenheit and pasteurization of milk kills the bacteria, but freezing, smoking, and pickling do not. The bacteria are killed by most common disinfectants. So hand washing and disinfecting knives and food preparation surfaces are effective strategies to decrease the risk of brucellosis. Giardia are single-celled protozoan parasites capable of forming cysts, which can remain viable outside a host for months. Giardia lamblia, also known as Giardia duodenalis or Giardia intestinalis, is the most common cause of giardiasis in humans. It's the most common intestinal parasite in the United States and the most prevalent protozoal parasite globally. Giardia is common in low-resource settings and in areas where waterways are contaminated by grazing livestock. Americans at the highest risk are international travelers, daycare workers, and backpackers or others spending time in the wilderness. Outbreaks in daycare centers have been attributed to inadequate hand washing by employees, especially after diaper changes. Fecal-oral transmission can occur when Giardia cysts are ingested in untreated water, contaminated food, ingesting contaminated soil, or ingesting cysts from feces directly due to inadequate hand hygiene. Animal-to-person transmission does occur, but it's less common than person-to-person transmission. Humans and animals infected with Giardia excrete cysts in their feces. An infected person can shed up to 1 billion cysts daily, and ingesting just 10 cysts is enough to cause infection. Giardia spend time between two life stages. Cysts, the dormant inactive stage, they can survive in the environment, and trophozoites, which have flagella to help them swim around. Giardia is one of my favorite things to find under the microscope because, as you can see in this stained slide, they look like little happy faces with their two nuclei. When Giardia cysts reach the stomach, the acidic environment causes them to undergo a transition called excystation. Each cyst yields two trophozoites, which use their flagella to swim to the upper intestine and anchor themselves to the wall of the duodenum. Within the small intestine, they replicate through an asexual process known as multiplication. During digestion, when the gallbladder excretes bile into the intestine, the change in pH triggers the trophozoites in the upper intestine to undergo encystation, transforming back into cysts that are then excreted in the feces and released into the environment where they may go on to infect another human or animal host. More than a third of people are asymptomatic, but for most, after an incubation period of 1 to 2 weeks, watery, foul-smelling, greasy diarrhea develops associated with nausea, abdominal pain and cramping, bloating, flatulence, excessive burping, and fatigue. Some people may develop a fever. The diarrhea can be severe enough to put people at risk of dehydration. If symptoms persist, people may suffer from weight loss in addition to fatigue. When people suffering from acute giardiasis aren't treated, they may have recurring bouts of the same abdominal pain and diarrhea for many years. Even in people who are adequately treated, symptoms may persist for months because of the disruption to the intestinal wall. For example, people may be lactose intolerant for months after Giardia infection. In a minority of individuals who have acute giardiasis, long-term symptoms can result. which is now classified as a cause of post-infectious irritable bowel syndrome, or IBS. We used to think that chronic Giardia occurred when a cyst was able to get through the wall of the intestine, where it would be harder to treat. But this pathophysiology hasn't been confirmed, and the most recent studies still don't know the exact mechanism, but it likely stems more from the increase in gut permeability, damage to the mucosal lining, and interactions between both the host immune system and the other microorganisms in the gut microbiota. Giardia induces a reduction in the intestinal barrier function, which causes changes both in the human immune system and also changes among the other microorganisms found in the human intestine. Giardiasis is diagnosed by the identification of cysts or trophozoites in feces, which can be done via microscopy, but usually 3 stool specimens collected on different days need to be tested, because this technique can produce false negative results. Sometimes it's hard to find cysts or trophozoites visually under the microscope, even if the person is infected. 3 ONPs, ova and parasite tests, remains the standard of care in most low-resource settings, but many newer methods are now available in higher resource settings, including nucleic acid amplification tests, antigen detection tests by enzyme immunoassays, and detection of parasites by immunofluorescence. When using a direct immunofluorescence assay, antibodies tagged with fluorescent markers are added to the stool sample and then incubated. Then, under a fluorescent microscope, the Giardia cysts glow green. This test also includes antibodies for Cryptosporidium, so both diseases can be tested for simultaneously. Direct immunofluorescence assays have the highest sensitivity and specificity and are considered the gold standard test, but a fluorescence microscope and special test kits are required, so this isn't available for low-resource settings. The standard treatment for giardiasis is metronidazole 500 mg 3 times a day for 5 days. The rate of metronidazole refractory giardiasis is increasing in recent years, but the mechanism of this treatment failure remains unknown. Treatment with an alternative agent is recommended in these cases. Giardia cysts are highly resistant to both chemical disinfection and desiccation. For example, even cysts on the surface of dishes washed and dried on a drying rack can cause infection when the dishes are used again. If using chlorination or other chemical water treatments, it's important to make sure the concentration is high enough, because Giardia cysts have that durable protective wall. Boiling water for 1 minute is the best way to kill Giardia and other pathogens, but this can use a lot of fuel, so it's not always the most efficient approach. There are many alternative options suitable for lightweight backpacking or living with an untreated surface water source long term. For example, there's lightweight, compact filters available that are rated to filter out Giardia spores and even smaller microorganisms like viruses. When I was in the Peace Corps, I built a system using a ceramic candle filter and a couple of buckets, which is a bulky and heavy setup, but I wasn't going anywhere, so that met my needs. UV water treatment with a SteriPen is also effective at killing Giardia spores if performed correctly, which involves agitating the water while treating it. Whichever strategy people use to treat their drinking water that suits their needs, it's important that people understand how to use their system. All filters need cleaning and maintenance periodically, and some strategies aren't suitable for turbid or stagnant water sources. There's no singular best way to treat all water for all situations. It depends on many factors related to the conditions of the water source, climate, and logistics. Like Giardia, Cryptosporidium is also a single-celled protozoan parasite. There are more than 40 known Cryptosporidium species, which can infect a wide range of hosts, including mammals, birds, reptiles, amphibians, and fishes. Cryptosporidium parvum is the main zoonotic species, primarily from cattle, but Cryptosporidium hominis is primarily non-zoonotic because humans are the primary host. Cryptosporidiosis is the second most common cause of diarrheal illness in children after rotavirus. An estimated 700,000 cases occur in the US annually. Like Giardia, Cryptosporidium also forms spores with a hard, protective shell resistant to chemicals. Cryptosporidium is chlorine tolerant. Outbreaks of cryptosporidiosis have been linked to public pools that were inadequately treated. Outbreaks have also been linked to unpasteurized cider, juice, and milk. Contact with animals, such as in petting zoos, daycare facilities, and restaurants with infected food handlers, have also caused outbreaks. Cryptosporidium oocysts are primarily distributed through the environment in bodies of fresh water. Transmission can occur through boating, rafting, swimming in pools, or even hot tubs. After an incubation period of about a week, most people develop a gastrointestinal illness with watery diarrhea, abdominal pain and cramping, nausea, vomiting, sometimes a low-grade fever, and fatigue. Immunocompromised people are at the highest risk of severe disease. Most people don't need specific medications for treatment. Avoiding severe dehydration is the focus of care for most individuals. Immunocompromised people may require additional medical treatment. People remain contagious for about 2 weeks after the diarrhea resolves. Cryptosporidium is not killed by alcohol-based hand sanitizers, so washing hands with plain soap and water is best. Cryptosporidium and Giardia have a lot in common, including their increasing geographic distribution, with the help of beavers increasing their range related to climate change and the northward expansion of the boreal forest. A study by Ahlstrom and colleagues found that 9 of 15 waterways in Anchorage that they tested contained Giardia or Cryptosporidium, and 6 of 15 waterways were positive for both parasites. Areas with humans and domesticated animals typically have high levels of contamination with both Giardia and Cryptosporidium. It just takes one person swimming upstream or a tiny amount of human or animal feces getting into a waterway for infectious oocysts to be present. People hiking in remote areas often make the argument that if no one has gone further than they are, then the water must be clean, or if they're at high altitude or near the water's source, then it's unlikely to be contaminated. But remember that birds are among the many species that can transmit both Giardia and Cryptosporidium. So if a bird could have potentially flown over the water source, you shouldn't drink it without filtering it or treating it. While the population of beavers rebounding following decades of trapping them for their fur prior to the 1900s is a factor in the expansion of beaver populations in North America, the rising average annual temperature is likely an important driver of this change. When beavers construct dams, ponds form upstream, which create an area of deeper water that thaws the permafrost underneath it. Using satellite imagery, Tape and colleagues mapped the distribution of 11,377 beaver ponds in Alaska. Their research shows the distribution of beaver ponds as of 2022. There weren't beavers in the northern tundra yet, but the researchers expect beaver ponds to increase more rapidly in future decades, with a doubling by 2050. In this image, the blue arrow points downstream, and the white arrows point to the prominent beaver dams. Using satellite imagery, they were able to show the change over time. Beavers have the potential to introduce Giardia and Cryptosporidium to areas of the Arctic where waterways aren't already infected, which could have an impact on other wildlife species that usually wouldn't come in contact with beavers, humans, or other species that carry those pathogens. Because Cryptosporidium and Giardia both rely on water to disperse their oocysts in the environment so they can infect new hosts, a warmer, wetter ecosystem could mean more zoonotic diseases. Beaver ponds cause permafrost underneath that had remained frozen for thousands of years to thaw, which releases carbon dioxide and methane. The warmer water also causes land that was previously frozen riverbank to thaw, which collapses and erodes into the water. Silt, sediment, heavy metals, and carbon from decaying organic matter all are released into rivers by this process. These changes to water quality and the landscape impact all species who live there, including humans, and alter the ecosystem overall. More water and less ice will reduce habitat for polar bears and areas for marine mammals to haul out, but it'll also increase habitat for species that rely on unfrozen water over the winter. Some fish species and plants may expand their range. The Arctic has warmed nearly 4 times faster than the rest of the globe since 1979. How these changes will impact each aspect of Arctic ecosystems is very complex and difficult to predict. So, ongoing research and surveillance will be needed to monitor for threats to the health of humans, animal populations, and the environment for years to come. In part one of this lecture on vector-borne and zoonotic diseases, I covered the terms used in epidemiology to describe the natural history of diseases, disease transmission, and changes in disease occurrence. Part two of the lecture provided an overview of diseases that are vector-borne, zoonotic, and both. About 75% of emerging infectious diseases are zoonotic, and 17% of all infectious diseases are vector-borne. The examples I provided are heavily weighted in the zoonotic category because they're all caused by agents that are present here in Alaska. Fortunately, as of 2025, we don't have local transmission of Lyme disease, malaria, dengue, or Zika virus. But as the climate warms, vector-borne diseases could potentially become endemic in Alaska in the future. The zoonotic diseases discussed are already impacting the health of human and animal populations in Alaska and the circumpolar north, and their incidence may increase with changes to human populations, the climate, and health of ecosystems. Zoonotic and vector-borne diseases illustrate the complex ecological and epidemiological interfaces between humans, animals, and the environment, underscoring the need for an integrated One Health approach to understand and mitigate these emerging threats.